Radiation and Brain Metastases. This is one in a series of videos on the website about cancer.com that explore the role of radiation to treat various types of cancer. Brain metastases are cancers that have started elsewhere in the body and have spread to the brain secondarily. This is separate from a primary brain tumor such as a glioma. Brain mets are the most common intracranial tumor in adults and are at risk with stage 4 cancer, particularly patients with lung, melanoma, and kidney that may spread to the brain commonly. The most common brain mets, however, arise from the lung or breast cancer and usually involve the upper or cerebral hemispheres of the brain. The symptoms can include headaches, weakness, mental changes, seizures. It's worth reminding patients that the symptoms can be on the opposite side of the body. Typical brain mets cause brain swelling and benefit often from Decadron or dexamethasone. The best test to find these lesions is usually a post-contrast MRI. Here's a study showing nicely the smooth edges of a brain met that pushes away the brain, makes it a good target. It's worth remembering every white spot is not a brain tumor, that was a stroke, and these patients had a brain abscess. Normally the radiologist can distinguish this. Most patients have multiple brain mets in 2/3 or 3/4 of the cases, particularly with melanoma and lung cancer. These are typical pictures of patients with multiple brain mets. Each of these white lesions is a separate tumor. It's worth remembering that a PET scan uses radioactive sugar, and since the brain uses sugar all the time, a PET scan is often a poor test to look for a brain met. Whole brain radiation is the most common form of brain radiation. Highly targeted radiation would be called radiosurgery. The best advice on management comes from the NCCN's website. It's too detailed to go through, but the details would discuss whether the patient would benefit from surgery, radiosurgery, or whole brain radiation, or whether a brain biopsy would be necessary to confirm the diagnosis. The management of these patients should be multidisciplinary. Whole brain radiation, as expected, includes the whole brain and protects the eyes. The lesions can be shown to shrink on MRI here at 6 weeks and 3 months. Here's another patient 2 months down the road. The tumor is slowly shrinking away. Here's another typical example at 6 weeks. The small lesion is already gone. The large lesion is shrinking. Here's another patient out to 2 months, and even out at 4 months it's still shrinking. And a patient with multiple lesions all disappearing. This was small cell, which is sensitive, but even more radio-resistant tumors such as rectal cancer and kidney cancer may benefit from whole brain radiation, such as these two cases. Typically with radio-resistant cancers we use radiosurgery, such as a gamma knife or cyber knife. It's a high dose to a small spot. This patient by 4 months the lesion was gone completely. This patient by 20 days it was almost gone, and again by 4 months gone completely. The negative is in this case the tumor has gone away, but a whole new tumor is developed in an unradiated part of the brain. The dose of radiation now has been pretty well established on what's considered safe and proper. 70 to 90% of the patients will respond. 50 to 60% will have significant response, both symptoms and signs. The side effects are usually mild hair loss, skin irritation, short-term fatigue, memory, headaches, and some hearing problems. The long-term risk of whole brain is called leukoencephalopathy, whether these white matter changes will reflect memory problems down the road. This usually takes a year or 2 or longer to show up, and studies do show it's the whole brain radiation that causes this, not radiosurgery. Many patients then prefer radiosurgery. It has a higher local control rate, less risk of memory problems, but 5 to 10% of the patients may develop radionecrosis, which is localized brain damage, as in this patient at 6 months, but this generally will go away on its own. The survival of a patient depends on whether the cancer is controlled elsewhere in the body, as well as their age and performance score. The RTOG class shows the median survival data with large numbers of patients. Remember, these are only averages. And the patients with the RTOG class 1 are most likely to benefit from more aggressive therapy. So in summary, brain metastases are quite common. They're often treated with brain radiation, either whole brain or targeted radiosurgery. The details can be found on the website aboutcancer.com.